and it gives me great pleasure to welcome to the stage Ms. Malebona Matsoso, who's the Director General, and for this week also doubling up as the Minister of Health of South Africa. She's a pharmacist and also has a master's degree in law, human rights, and governance. She was previously on the executive board of the World Health Organization and was a commissioner of the Global Lancet Commission on High Quality Health Systems in the Sustainable Development Goals era. They released their report in September last year. So over to you, DG.
Good morning. Thank you very much, Professor Rispel, and I would like to also thank you for inviting me to address this meeting. It comes at a time when the World Health Assembly is debating various issues. As you know, how we reached 3 billion. As member states, we are really humbled that the Public Health Association, in particular the World Forum, like this one, has taken interest in issues that I consider to have been high on the agenda of WHO. High on the agenda of WHO because you probably saw over the number of months, we've seen headlines, measles outbreak in both developed and developing countries. Now those headlines should actually be a signal that as we reprogram and try to reach the 3 billion, we obviously have to start making sure that we still do the basics that are enshrined in public health. Immunization is the most precious gift that a healthcare worker can give a child. When we immunize children, women, the elderly, we prevent death, we reduce suffering from disease, and we also ensure that we give these children an opportunity to live and also deal with their childhood illnesses. Immunization against these diseases, whether it be measles, polio, diphtheria, whooping cough, tetanus, hepatitis, remains the most cost-effective public health intervention currently available. And health workers that are involved in immunization are actually in a privileged position. Privileged because they are the ones who can make this happen. Privileged because they are the ones who can ensure protection. So EPI is one of the most successful and cost-effective public health initiatives to reduce infant morbidity and mortality from vaccine-preventable diseases. Of course, the benefits of immunization are so immense that it is befitting that in 2011, the World Health Assembly declared the decade from 2011 to 2020 a decade of vaccines. I was actually thinking that 2020 is actually a year from now. It cannot be that a year from now we have a measles outbreak, not in one country, but in several countries. For those of you who might have been at the World Health Assembly, you could have listened to a few member states, starting with some of the countries in the Caribbean islands, who said we could not allow that ship because of possible and potential outbreak of measles. But they not only stopped with the measles, but they said they were also worried about a potential outbreak of yellow fever. So if we look at that, we'll be at least reassured. Reassured because target 3.8 of the Sustainable Development Goals emphasizes the importance of immunization because it calls for access to safe, effective, quality, and affordable medicines and vaccines for all by 2030. So it calls on us to ensure that there's improved coverage by 2030. But in addition, the Global Vaccine Alliance, Gavi, also called for universally acceptable and applicable vaccine indicators to reach and sustain 90% national coverage and 80% in every district with all vaccines in the national programs. I'm emphasizing this because an institution and an association like yours should actually be the leader, should be at the forefront of holding us to account, of reminding us of these targets. We support this and believe that it should be achieved. Rodrigo earlier referred to the worldwide figures of vaccination. And I think that those infants that should be immunized under 1 year of age must still receive those. They should not be left behind. I'm raising these globally because I have to contribute also to those global statistics in South Africa. I am not excluding myself. So the global movement calling for access to safe and quality vaccines is probably something that you should also take interest in. As we tackle vexers, but also make sure that we can make these vaccines accessible. In line with the principles of global immunization vision and strategies, South Africa took the lead in introducing new vaccines in an effort to provide additional protection for children for some of the most common mortality and morbidity. We introduced rotavirus for diarrhea and pneumococcal vaccine as part of the EPI schedule. We introduced HPV vaccine, and we also moved from just having 6 vaccines in our expanded immunization program to 11 antigens in the EPI program. I'm raising this because this expansion started in 1995 when hepatitis B vaccine was introduced, targeting health workers, inclusion of hip vaccine in 1999, and so on. I can go on and talk about when each vaccine and when we changed from tetravalent vaccine and when we started buying annually influenza vaccine. But I don't think it's enough. It is not just about introducing these new vaccines, it is also about coverage and guaranteeing that we have coverage. I'm actually sad and happy in that from 2010, our coverage was 80%. In 2015, it increased, and in 2016, we were at 89.2. But subsequent to that, coverage dropped. So this drop was worrisome. The results over this period seem to be showing optimism. But when we looked at disaggregated data by province, we saw mixed results, with the best performing province sitting at 96% and the worst performing province at 69.5%. So it's quite clear that the inequalities within the provinces and within the country calls for us to respond differently. Precisely because immunization is provided free of charge in the public sector, in that it removes financial risks to users, with a key component of focus as ensuring that everybody is covered. So, if that is the case, we still have a proportion of people in South Africa who use the private sector. And our concern is that the private sector does not necessarily immunize. So it worries us that when we run a two-tiered system, you miss others. And our call is that when we talk universal health coverage and national health insurance, it means everybody must be covered, whether in the public or private. Every child and every woman or every elderly who deserves to be immunized should be immunized. We obviously have established different expert groups just to share with us what is it that we need to do to target specifically the underperforming provinces and some of the sub-districts. But what we also did was to say, you can't just introduce new vaccines and you don't assess whether there's been a benefit or an outcome. So when the pneumococcus vaccine and rotavirus vaccines were introduced as part of the EPI program, we asked our National Institute for Communicable Diseases to set up a surveillance system and assess the impact of these new two vaccines. Firstly, on the incidence of pneumonia and diarrhea. So the report we got was that we had actually a more than 40% reduction in pneumococcal diseases in all ages since the introduction of pneumococcus vaccine. But the greatest decline was amongst children below 2 years of age, which is the age that carries the highest level of disease. In addition, they also found that there was 34% decline in pneumococcal disease in people who were older. Besides this impact, NICD also reported that they were seeing a difference in antimicrobial resistance. But we still need to understand that, particularly for penicillin, ceftriaxone, in particularly the resistant strains of pneumococcus. So it's sort of a development that we're not aware of, but we wanted to understand that better. Similarly, surveillance on the impact of rotavirus showed that the vaccine resulted in 40% reduction in hospitalization of children with diarrhea and 60% reduction in hospitalization, particularly from diarrhea that was caused by rotavirus. But we believe that just giving rotavirus vaccine alone is not enough. If you do not have good hygiene practices, if people don't have access to clean water, and there's a problem of sanitation, meaning these must be supported measures that go hand in hand with vaccination. So our vaccination program continued to serve as a strong platform to integration, not only for child health services. When mothers bring their children, they are also assessed. You get an opportunity to test them for HIV and AIDS. You get to know about their status, and you get to also assess them for TB and other related diseases. So this must be seen also as an entry point to assess the health of the mother. It is is an important platform also to check whether for those mothers that are on ARVs, are they on treatment, do they adhere? Meaning, the immunization program for us has actually helped us to also use it as an entry point to monitor our HIV/AIDS program indirectly. But it also introduced a very important program. As we started school health, we partnered with the Department of Education to introduce HPV. HPV is introduced in schools for learners who are in grade 4, and we cover about 400,000 of them annually. And so far we've got 1.2 million of them who have been given HPV. So for us, providing immunization and vaccinating children and these young adolescents, it's important. And we're hoping that it's a key program that must be defended as we move towards universal health coverage. But what does it mean, for instance, for us? Like I said, we have a decade of vaccines, we are 1 year left, and we're seeing these other trends. But we're actually 11 years away from reaching SDGs. So 11 years from now, there should actually be true coverage, because immunization is a major entry point for attaining SDGs. It will help us because it has the potential also towards, in my country, dealing with inequalities. We'll have an opportunity to bring about harmony between the public and the private sector. But there's a worrying trend that we see. A worrying trend because SDG 9 actually calls for an opportunity for research and development and manufacturing of vaccines. Manufacturing should ensure security of supply that is dependable and sustainable. We've seen shortage in 2018 of BCG. We've witnessed in 2017 shortage of hexavalent vaccine because the manufacturer was unable to meet the demands. We've seen most recently a worrying threat of shortage of tetanus and diphtheria, again a supply problem that cannot be met. So these shortages show the vulnerability not only of South Africa, but a few other countries that depend on global supply. And I think for that reason, this will undermine our efforts, our prevention efforts, but also it will reverse the gains that have been made. So in your call to action, I've got a message for you. And my message is that let's not allow complacency of people like me as the Director General, complacency of parents who do not think immunization is important, complacency of health workers who do not do their work, but also complacency of the suppliers who do not supply enough vaccines globally. So be the monitor for us and introduce a barometer. Be the watchdogs and defend public health. My department will be running a surveillance, but I would like the results to be made public so that you can be the judge. As a watchdog, you must say to me, here you are, you've done well, or you haven't. So this survey for us will be significant. I'm hoping that by the end of this year, I'll have a National Public Health Institute of South Africa, because there's a law in Parliament to establish such. And in South Africa, we will not have universal health coverage, and neither will there be national health insurance if this Public Health Institute is not established. No Public Health Institute, no NHI, and no AHC. Thank you.
Thank you very much, Director General Matsoso, for bringing so many of the themes that we're hoping to address, and importantly for also reminding us of our watchdog role and for holding public officials accountable in the interest of the public's health. So thank you very much for that. I'm going to move on to the World Federation. Would like to hand over a small token of our appreciation by acknowledging you as an ambassador, what we call a diplomat of the Global Charter for the Public's Health. And we had the Geneva headquarters had initiated it and had put the idea to me in recognition of your efforts since January this year, both with agreeing to come to us and despite your busy schedule, also in helping us to fundraise. But I think after your speech, you've just confirmed that you are indeed a very worthy recipient of an award to be a diplomat of the Global Charter of the Public's Health. So I would like to hand that over to you.
And I'm actually humbled by this. Humbled because, you know, as public servants, we think that it's our job to go and speak wherever we're called, we just go. But I've never been called a diplomat, but I'm trying to perform. We can use a scorecard and see whether I've really do advocacy for the Federation. And thank you so much. Thank you. It's appreciated.
There's some very interesting issues that the Director General has highlighted in her speech, and I was wondering if there are any questions or comments.
Good morning. I am Madhav, working in the Global Vaccine Safety Team here in the WHO headquarters in Geneva. Thank you very much for a very interesting and a very useful, informative discussion and lectures. Now the thing is, something which I wanted to bring to the notice is actually one of the things which has never been touched before, particularly here since the morning, was also the challenge which we are going to be facing in terms of falsified vaccines. We are beginning to face this challenge in a very big way right now. For instance, we are beginning to face fake vaccines which are slowly entering into the market. The reason why I brought this to your notice was because you were just talking about the private sector. And many people have a feeling that, you know, if you, particularly in the urban areas, if you go to the private sector for treatment, you may end up with so-called better quality vaccines. Unfortunately, what is also happening is the private sector, particularly vaccines which are being administered in the private sector, are actually not monitored or supervised as much as what is done in the public sector. So what is happening is, we have had instances in certain countries, like we have had it in Indonesia, Bangladesh, in several countries in Africa, where we had problems where vaccines got into the fake vaccines have started getting into the systems. So it's very important for us to keep this in mind, particularly as we move forward. So it's not enough to be just looking at the routine things and trying to promote just coverage, because the vaccines which we administer may end up being useless. Thanks.
Okay, thank you.
Thank you. My name is Erich Kofmel. I'm with Autistic Minority International. I hope to be saying a bit more about autism and anti-vaxxers at a later point. We are very concerned about pathologization of autism, which in our view contributes to this social media outcry over vaccines causing autism and vaccine hesitancy based on that. But my question right now would be about HPV vaccination. We have submitted a comment on the draft global strategy on the elimination of cervical cancer to the WHO just this month. And we are very concerned that this draft strategy does not mention women with disabilities. And I'm wondering what the situation is in South Africa, because you mentioned HPV vaccination. Women with disabilities need to be vaccinated for HPV. There needs to be HPV screening. There needs to be pre-lesion screening, and there needs to be cervical cancer screening and treatment. And all of this does not take place because there's an assumption that persons with disabilities are not sexually active, so they don't need to be vaccinated. And I wonder if in your program, where you said that there is HPV vaccination in South Africa, if you are including persons with disabilities.
I'm Dr. Philip Ijinlo from Taiwan CDC. So the problem is not only with manufacturers unable to meet the demand, but also some is the quality issue we call vaccine. And usually it allows us very short window to find other suppliers and to meet the vaccination program. Otherwise, it could generate public anxiety about not having enough vaccine. And the quality issue also trigger public suspicion about vaccination provided by the public sector. So I want to ask your experiences in how to manage this problem in a country level or in a regional level.
Thank you. Just as well, just to say I'm a strategic advisor for the Interaction Council and former head of health for the Commonwealth. Loved your presentation, really interesting, and particularly I just wanted to know a bit more detail about your plans for setting up the Public Health Institute, and also maybe the relationship with the Global Charter for the Public Health in relationship to the Institute. Thank you.
Hello, I'm Thomas Hausmann. I forgot to mention I'm here with the International Federation of Medical Students Association. I'm a medical student. I really liked your call to action in regards to complacency. I have a question. Since we luckily use more and more vaccines in more and more countries, that also means that that's a really good thing, but it's also we're not going to reach everyone always, as you were saying with UHC and the private and the public sector. So my question is, demographically speaking, we replace fully immunized elders with partially vaccinated children. So my question is not being complacent enough? Does it mean we have to become better?
I would first start with the National Public Health Institute. That we actually went through the public hearings in the whole country and regions. I mean, it was a very interactive process. We got public health experts giving inputs, civil society organizations. It was a robust process. So this law should have been passed by this parliament, the outgone parliament. But the day they were supposed to pass it, they had put it as an addendum. I think it was just an administrative thing. So it's going through this one, and it will be one of the first bills to go through. And as a new diplomat, I will ask that they adopt the charter. Is that the way to go? I need to be guided. Can the National Public Health Institute adopt the charter?
Yeah.
This charter. Is it allowed?
Yes.
Yes.
In that case, I commit that I'll ask them to adopt the charter. The second, the question from the colleague from, is it Taiwan? Yes. You asked about the strategies. We have established a forum in South Africa. But civil society, when I spoke about activism, civil society has established what they call the stock out. So what they do, they are almost like an early warning system for us, because they say there's a stock out and we know already. And then as part of our monitoring system, we'll know that it's not just one vaccine in one facility. It's a national problem. So as part of that forum, we installed, in this day and age, there's this potential for artificial intelligence, fourth industrial revolution of introducing information technology. So we introduce information systems in every single clinic to monitor the stock levels of all supplies, pharmaceuticals, vaccines, and so on. So it's sort of a trigger. Once they run low, it must be a trigger to say, provide supply. But equally, we established what we call a central tower, where we monitor the manufacturers and the suppliers. So if a supplier doesn't supply, we already know we contact them. Equally, if a clinic doesn't order, we already know we contact them. So these two systems have helped. But if there's a global shortage, then we sort of ask WHO to convene different players to just discuss the global shortage of medicines. So it's one of the initiatives that we thought needed to be coordinated globally, because South Africa alone cannot do it. For instance, when yellow fever went out, it was a problem because it meant you couldn't allow people without yellow fever vaccination into your country. So recently we were told that Brazil has actually increased their capacity to produce yellow fever, not just for Brazil, but for the world. So these kind of efforts help, but I think we have to constantly monitor. But we also think that manufacturers should be encouraged, to continue supplying, because others, if it's no longer profitable, it's not worth the effort for them. So we need to keep on engaging and encouraging them, perhaps through volumes as a group of countries. So in the SADC region, which is a group of countries in the southern part of Africa, we've come up with a joint procurement strategy. So we've just started that initiative. We hope it will be one of the solutions. We don't know. But one of the things that manufacturers complain about is what I refer to as delays in regulatory approvals. And we're trying to work with regulators also to approve the products timelessly so that access cannot be compromised. The question from our colleague regarding HPV vaccine and access for people with disabilities. At the moment, our HPV was mainly for 9 and 10-year-olds. It was for young girls. But I think we have separately a strategy on disabilities to deal with all the needs of people with disabilities. So we've not confined it only to one particular area. But I think it is important to note that our disability strategy was not just developed by people. We actually have someone with disabilities in the department driving that agenda broadly, in a broader sense, including, some of you may not know that we have special, when people do marathons, it's for people who can run. We have marathons for disabled people only, where they themselves enjoy that. So we've got targeted programs for people with disabilities. But I can go back and check whether is there a specific thing for HIV. Yes. So the third question was about quality and falsified, the term that WHO uses, it's so long. And I can't even say the acronym, but falsified and counterfeit and whatever, that description. I think it's a general problem even for pharmaceuticals. I don't think, in South Africa, when I say the private sector, I'm actually talking about insured patients cannot access those medicines. They have to come to the public sector, and sometimes some just give up and they don't necessarily follow. So we're saying that coverage must be broader in that sense. I mean, counterfeit, if it's a problem for pharmaceuticals, it will be a problem. If you don't have a robust regulatory system with capacity to enforce, it will be a problem generally. So some of the measures, like I was explaining, these monitoring systems that we have actually proven to be very good to monitor quality. There was, and this difficult question that I didn't understand about complacency. You were trying to establish whether is it parents who are complacent, and what would be our strategy to engage them? Well, I think it goes with education and health promotion, obviously. Like I said, you can't just, vaccination alone is not enough. It must also go with other health promotion efforts and education, like we ordinarily would be. And I think it goes even for health workers and for communities. So we still need that effort. Just as a parting shot, I just wanted to share a very humbling example about, South Africa has migration problems like Italy has. Maybe you hear from Italy how they deal with immunization or vaccination for people who cross borders. In South Africa, we've got migration from Zimbabwe largely and Mozambique. I have never seen a woman come with a child and their health growth chart. They carry them crossing the border and they tell you, I'm from Zimbabwe. This is my child's immunization schedule. So it just shows how education has contributed in Zimbabwe, even with the resource constraints. Even in Mozambique, they still bring their cards to our facilities in South Africa. For me, it's a good sign on how you can empower a woman, because they know they have to carry this with them, even when they cross the border, whether legally or illegally, but they still carry it with them. I thank you.